the principal investigator of the highly acclaimed Blueprint study, and the inventor of the alcohol monitoring test. And I'm blocking on the name. He's a highly respected MRO. Before we bring him on, I'm going to ask you to just do a brief poll of focus questions that he will address during his presentation. Please go through and mark your answer. It's not meant to be a test, but it does simulate continuing education type pretest format. Give you a couple minutes to do that. We have one participant who can only see banner slides, so we're going to try to do that. And it gives me great pleasure to introduce Dr. Greg Skipper, my dear friend and colleague. Thank you. And there you are.
Okay. Am I good to go here and start talking a little bit about our subject today?
I believe you are.
Okay. So it's a little odd doing this without having the benefit of seeing everyone. I'm at home here in Southern California. I've been hibernating here and practicing sterile technique for the last few weeks, as I'm sure some of you have. And so welcome to this, this brief presentation. So we're going to talk about the crisis of physician health in California today. In 1978, California was one of the first states to initiate a physician health program, and they called it the diversion program, which I think is a poor name for the program, and we'll talk about that a little later. The program was closed in 2007. So we'll talk about why that happened. So now California is one of the only states, only one of a few states that lack a physician health program, which is particularly unfortunate since California is the largest state, has the largest population of physicians. So everybody probably here, I know some of the folks attending may not be working with physician health programs. So this can be generalized to any professional health program. So if we're talking about pilots or attorneys or dentists or any other licensed professional, they're all governed by some kind of board. And, you know, medical boards and most of the other types of licensing boards began over 100 years ago. So it wasn't until the late 1800s that we had licensing boards at all. And initially the licensing boards just verified that somebody had graduated from a legitimate professional school and were competent to practice. And so for 50 years, that's what they did, is they licensed people that got out of professional training, and there was really no renewals. People were licensed once and forever. Starting in the 1950s, boards started coming up with the idea to do a test. So initially for physicians, it was called national boards. Now it's called the USMLE, and it's gotten more complicated. But in the 50s is when the regulatory boards started offering testing and requiring testing as part of licensure. And then in the 1970s, a new evolution occurred in that the boards not only required renewal every 2 to 3 years, most boards, but and required testing, but they also really got more interested in investigating complaints. And so boards became much more active in terms of investigations, hiring investigative staff, and disciplining physicians. So in the 70s is when the issue came up of physicians with substance use disorders and also attorneys and pilots in that same period of time in the late 70s. The question came up of, should they be disciplined or is there a better way? And so we'll talk a little bit more in a minute about that better way. But in fact, we know that almost every group that's been studied has a significant lifetime prevalence of substance use disorders. And physicians in different articles have had anywhere from 10 to 15% of physicians in their lifetime will have a substance use disorder. The most recent paper on this was by Mick Oreskovich, who formerly was the director of the Washington Physician Health Program. But that paper was published in 2015, where they looked at 27,276 physicians. It was a survey, and they found that 15.3% admitted to having had a substance use disorder. So that's kind of consistent with other studies, maybe a little higher percentage, but anywhere from 12 to 15% has been the number of physicians that have a substance use disorder during their lifetime. So this is a kind of a startling fact that many physicians have problems. And again, this is common with any group that's been looked at. So the point of it is that this fact should not be ignored. We have to deal with this problem, and we need to have a competent plan to deal with it because of, to provide for patient safety. Because as physicians that have substance use disorders get sicker, then they can become impaired, and that can be a risk to patients. So physicians and other professionals use drugs and alcohol for the same reason that anybody does, is for relaxation, stress reduction, because of personal trauma, chronic pain. People self-medicate. And those that are susceptible to a substance use disorder can slowly progress over time and develop the illness of substance use disorder. And it can cause impairment, as I said. So since we have such a significant percentage having this problem, it's important to think about early detection, because we know that the illness progresses. So the sooner we can intervene, the better. So, physician health programs have evolved to deal with that. And I think in large part, they've been highly successful. The AMA, the Federation of State Medical Boards, the Joint Commission, the the American Bar Association, the FAA, all have endorsed programs that provide for early detection and management of these kinds of problems. Stigma is sort of a barrier to dealing with this. Mental health disorders and substance use disorders in particular, are susceptible to stigma, and that is a barrier to people getting help. Also, medical boards and other regulatory boards have developed, some of them in different states, have developed reputation for being prone to punishing licensees. And so that's a barrier to early detection and leads to isolation of those affected. Also, we have a barrier of dealing with this in that there's a lack of training and understanding of how to approach it. And so physician health programs provide that expertise. And the lawyer assistance programs and the HIMSS program have specialists that provide, that know how to deal with these things effectively. So this system of care evolved in the 1970s to address this problem. And like I said, every board, regulatory board has endorsed programs. In the physician world, we generically call them physician health programs. And unfortunately, as I mentioned at the beginning, California discontinued their programs, and we'll talk about why in just a sec. So the question comes up is, are these programs really effective? Well, we know that physicians that have substance use disorders struggle with these problems. They're embarrassed, they're afraid, they're discouraged. They're particularly discouraged because most people with a substance use disorder, including professionals, make many attempts to try to cut down or quit or deal with their problem. They don't want to have the problem. They want to be healthy and get better, but they're afraid, and they're afraid for their secret to become known because they're afraid of the consequences. So they become very discouraged, and denial is definitely part of the illness. And so symptoms usually progress, and they progress until people around the person, their family or their associates or colleagues, see the problem more clearly, and eventually someone acts to intervene. So if there's a well-functioning, confidential, authorized program like a state physician health program, they can be contacted and come into action immediately. So unlike the slow machinery of administrative law, where you have lawyers and evidence and investigation and all that, a physician health program can be a clinical tool to contact the physician, do an intervention by offering them help and getting them help, and that is what we're hoping will happen. This early intervention is sort of the most important function of a physician health program. So the PHP would contact the doctor, let them know there's a concern, and recommend that they go for an evaluation. So the question comes up of why would a physician cooperate? Why would they work with a physician health program? Well, number one, I really believe that secretly, every physician, every professional that has a substance use disorder wants help. They're just afraid to ask for it. And so when a program comes along that's actually compassionate and confidential, the physician, if they're convinced of that, can accept help. Also, of course, once it becomes an issue, the physician can be informed that if they choose not to accept help, that it may well be reported to the regulatory board, and then the administrative law function will come into play and eventually may require them to get help. So most physicians and other licensed professionals dread the idea of being involved with the legal component of their board. So they're willing to accept help, both because they really want it secretly, but also because they realize they have to do it because otherwise they might get in more trouble. So if it's presented properly and compassionately, a huge percentage of people do accept. And so this model has been proven very effective. So why does California not have a physician health program? So, they called it the diversion program. It was run by the Medical Board of California, and it was a diversion from disciplinary action. So over the years prior to its closure, over about 8 years prior to the program being closed, several audits were done, and the award to run the audit was made to a consumer protection group called the Center for Public Interest Law. So they conducted several audits. They found problems. And I would say that every physician health program has problems. When you're dealing with people that have substance use disorders and you're monitoring them, it's never perfect. So the problems they found were ones that I think are pretty understandable. They found that all the reports were not getting in. So if part of the agreement was that the physician would see a psychiatrist or a psychologist periodically and reports would come in, they found that a percentage of the individuals they looked at, those reports were not coming through and not coming into the diversion program. They found that sometimes it took a week or slightly more for doctors to be taken off work after a positive drug test. And part of the reason for that is that it takes a week or so to get the results back. But they would look back to when the test was obtained and said it was too long of a time. But that's just the nature of the problem of testing. Another concern that the diversion program audits revealed was that testing dates were changed. So the doctor would call in and ask, presumably, for a change in testing date, and the audits felt that that was totally inappropriate. And it didn't say in the audit why that happened, but my belief is that it happened because of vacations. So when a physician was going to be out of town or on vacation, they could request to be suspended, period, when they weren't practicing and they were traveling. And the auditors felt that was totally inappropriate for them to be able to change their dates. So, there was no medical director to the program. It was run really by the medical board rather than being independent. And it was subject to these audits. And eventually, because they also found some patients that said they'd been harmed by impaired physicians, and they were kind of paraded before the medical board, these patients. And also media attention was attracted to the issue. For example, Anderson Cooper 360 did a special on it. And all this clamoring and concern came forward, and the medical board just decided to not renew the program. So in 2007, it was decided to close the program. It ended in 2008. So there was 200 or so participants that had to be dealt with, and it was quite a shock to those that were involved. So soon after that, attempts were started to begin a new program, and several laws were put forward. Finally, in 2016, law was actually passed requiring the medical board to establish a new program, but it's been totally bogged down in politics and concerns about the rules and so forth. So it's been disappointing that we still do not have a physician health program in California. So what happens to physicians in California since there's no program? So basically, physicians in California that have a substance use disorder are punished by the board. The board sees it as a legal issue that they're basically committing crimes to be impaired. And there's really no emphasis on early detection, rapid intervention, evaluation, or treatment. So basically, substance use disorders are handled as crimes rather than illnesses. It's at great cost to the state and to the doctors to do it that way, because the judicial apparatus of the state comes into play with the Attorney General's office. Accusations are filed, investigations ensue. It takes years for this process to occur. And sometimes the board actually refers doctors to criminal authorities, increasingly in the last few years. And so all of that makes physicians loath to be involved with the program, or with the board in California. Hospitals are required in California under law to report any physician that's being investigated for possible substance use disorder. So even if they don't have a substance use disorder, they're investigated. If they're under investigation, they have to be reported. And then the board comes into play and does their own investigations. Many hospitals now, because of this pressure, have not followed the Joint Commission standards of a process for doctors that are having difficulty to get help and not be punished. So the hospitals under pressure have basically given in to their lawyers recommend that they just report any physician that has a problem to avoid liability. So we see that happening a lot here in California. The medical board in California has done some activities that are really harmful in a way. They've at great expense developed an app that patients can put on their smartphones, and they put their doctor's names in this app, and then their smartphone alerts them if their doctor is under suspicion or if they're disciplined. Also, a new law last summer came into play that requires doctors on probation, which now every doctor in California that has a substance use disorder ends up on probation. So any doctor that's on probation now, according to this law, Senate Bill 1448, is required to get a informed consent from new patients. So this basically means that a lot of doctors' careers will be ending when they have a substance use disorder. If this requirement is imposed, it's hard to imagine that they could continue to practice if they have to get a signed consent telling the patient about their probation, the terms of the probation, the reason for the probation, and so forth. So basically, the Medical Board of California has shown aggressive zeal in punishing physicians, and it's definitely not set a tone for early detection. Also, when the medical board puts doctors with substance use disorders on probation, they rarely recommend treatment. The thinking is that the board is not there to help physicians. The board is there to protect patients. And as accurate as that may be, the problem is that healthy physicians help patients. So these issues of helping physicians be healthier and having safety for patients are not mutually exclusive. They should be thought of together. So creating an atmosphere where doctors can come forward and get help for their problems increases patient safety. And so when we deter that, when we set an atmosphere where doctors are not comfortable getting help, then that increases risk. But that's a hard sell in California. The consumer advocacy groups really believe that more doctors should be punished and removed from practice, and that will make patients safer. And I really think that is not the case. So a huge amount of money is wasted. Treatment is delayed, and patients are actually harmed through this process. And you can see it if you look at the cases which the board actually posts and look at how they've evolved. From the time of a complaint to the investigation is usually about a year, and then it's usually another year before any action occurs. And there's numerous cases where more harm has occurred due to this delay. So in this hostile climate, physicians are afraid to seek help. Colleagues, hospitals, families don't want to make referrals. Hospitals are forced to because of the law and fines if they don't. So substance use disorders go unchecked, and patients have been harmed. We've had recent cases where one doctor was even charged with murder because of his substance use disorder when a patient died. And in that case, it was clear from looking at it that there were numerous times over the previous years that he should have been and could have been reported and gotten help sooner, but that did not occur. So we need a program where there's early detection, and that's what physician health programs can do. A good physician health program can set an atmosphere where early referral is more likely. So as I said, the legislature in California did pass a law, and we're hopeful that eventually we will have a physician health program. But the law was passed in 2016, and now 4 years later, we have no program. Over these years, there's been many meetings where there's been wrangling about how to operate the program, what the rules will be, whether there'll be a confidential component, how punitive it will be, how the drug testing will occur, how restrictive it will be. And there really is not any clear sign that at the moment an effective program will emerge. So it's a sad situation that we don't have a physician health program here in California. And again, I believe that it increases patient risk to not have an effective program. So let me see what the polling data showed. So the first question was, in your opinion, which of the following is the most important function of a state-of-the-art physician health program? So education, intervention services, create an atmosphere that encourages early referral. So that got the most votes, and I agree with that. But all these other functions are important. Referral of participants for evaluation, long-term monitoring. But in fact, those functions, referral and long-term monitoring, can be done without a physician health program by the board itself. So I really think that the most significant reason to have a physician health program is to create an atmosphere where there can be early referral. Question number 2 was, in your opinion, what is the most significant reason physicians or other licensed professionals agree to participate in a physician health program? So the first response, they secretly want help but are afraid to ask for it, I think is probably the most significant reason. Although it certainly is true that they don't want to be referred to the medical board. So that's an added impetus for physicians to accept help. What do you think is the most likely reason the PHP in California was closed? So a couple of responses here. Intense media pressure generated by consumer advocacy groups. That would be the one I would think. Lack of funds to continue the program. There was funding through license fees. So that really was not the reason, although when the funding was pulled, of course, the program closed. But the reason the funding was pulled was the intense media exposure and those audits that I mentioned. The fourth question was, which of the following is most damaging to physicians in California? And of all those, the answer is all of the above. And the things that are going on include that every hospital is required to report any physician when an investigation is opened or a physician is disciplined. That means that physicians will be referred to the board. The fact that the board takes years to prosecute an impaired physician and they don't refer them for treatment is certainly damaging. The app that patients are encouraged to put on their phones to track whether their doctor is disciplined, certainly doesn't help the early detection. Doctors do not want to be involved in this. And the board requires that a sign be put in every doctor's office advising patients where to make a complaint. Certainly encourages complaints. And then the law most recently that requires that doctors get informed consent of new patients if they're on probation is definitely a concern. So that concludes what I was going to talk about today. I want to see if there's any questions. Do we have any questions? Let's see. Jim, do we have any questions that you know
of? There was a question from Dr. Specht about where is the protest, but I actually don't understand what his question is. Do you hear me?
Yeah, I hear you. So just guessing, I would think that probably what he's talking about is why is there not more concern about this? And I think because it's a somewhat complicated issue, it's hard to put in sound bites. So it's hard to get the public interested and understanding clearly. So it's easy for these consumer groups to set it up that saying that there's bad doctors out there that are hurting patients and we need to get tougher. And so the public does not really understand it. And so there's little protest of the situation. Any other questions, Jim?
Yes. How does the California situation impact or put other state PA?
you kind of blanked out there, Jim. I think what you're saying is, how would the California situation impact other state programs? Well, to some degree, there's been a little bit of contagion here in that what's happened in California is spreading to other states. I know Oregon's had similar attacks on their program. And the Center for Public Interest Law has tried to create the same commotion in other states. So this problem could spread, and I think it's important, I think, for physician health programs to be proactive and work with consumer groups and help people understand that the program actually increases safety for patients. I know in Colorado that's been very effective. They've had a consumer group aligned with the physician health program to promote the fact that early detection and helping doctors be healthier creates safer care. Other questions?
Yeah, we got one from our friend Michael Ramirez. In your opinion, what is the path forward to opening a PHP in California?
We're kind of bogged down. Thanks, Mike, for the question. You know, I've attended several of the hearings, and the problem is that as I said, that it's being so encumbered by restrictions and punitive aspects to the rules that I'm not sure if it opened today, I don't think anybody would want to be referred to it. So that's the issue is, you know, if the most important function, I believe, of a physician health program is to encourage early referral, early detection, and early intervention, having a punitive program just won't make that happen. So that's the barrier. So how can we move forward? You know, we've tried to, there's a group of us that have tried to get state legislators interested in promoting this. And I think maybe that's the only way forward, is to get leadership at the state level interested in making it happen. But to date, that has not occurred. Any other questions? Yeah.
Dr. Skipper, our friend Dr. Specht asked, is there any progress on reducing the requirements that a new program follow all the requirements of Senate Bill 1441, which is largely punitive?
Yeah, thanks, Tom. Senate Bill 1441 is kind of unique in the United States in that it's a law that says how substance abusing physicians or any substance abusing professional has to be monitored. So it's when you read that law, it makes you realize it's absurd because think about what if the state legislature passed the law of how you manage diabetes. It would be ridiculous. You know, state legislators are not physicians. They don't know about the intricacies of management, and it's hard to put it in a law. But that's what they've done with Senate Bill 1441, is it basically describes how to do drug testing. It's not a very clinically oriented process, and so it is seen as punitive. For example, if a doctor tests positive before it's even vetted by an MRO, the doctor must cease practice, and there's rules about how long they must be off practice, with how many tests would be negative before they can go back to practice. So we've seen some real problems with that. So we've had hearings with the board hoping to get some of the rules changed. To date, to my knowledge, that's not happened. And I think the reason it's not happened is the continued pressure from consumer advocacy groups to punish. And we see that at these hearings. They come forward and they actually have developed quite a way of making their case, and nobody wants to challenge it today. So we're stuck. Any other questions? I would, if I could control it, I would actually unmute some of the folks. Oh, there we go. Let's see. Any other questions? Does anybody want to make comments? We have, it's only a small group attending this. So maybe I'll unmute everybody if I can. How do I do that? Unmute. So if anybody wants to make comments, feel free.
Hi, Greg. It's Ann Glassmore. Can you hear me?
Yeah, I sure can. Hi,
Oh,
Ann.
good. Hi. I just wondered if you know anything about the new director for the Medical Board of California, if we can anticipate a more receptive attitude from him. I think he starts in January.
Yeah, I'm hopeful. I don't know him. I read his bio. Change can be good. So if anybody knows any more about him, that would be great to hear. But I don't really know anymore.
Okay.
Anybody have any comments about that? Okay, any other comments? Anybody have?
Hey, Greg.
Yeah.
Greg Abrams, lawyer in Oakland.
Hey, Greg. I'd like your thoughts on what I've said.
Yeah, I mean, you're spot on. I think, you know, the question about an actual PhD in California, I'm a lawyer. I do everything through a lawyer's classes. It just seems
Right.
to me that train has gone away. We have now, as I understand it, all the licensing boards for healthcare professionals, other than the medical board, using Maximus as the program when you are on probation for substance use disorder or whatever it may be. The medical board is still cranking and cogitating on it because they want to have their own, we're talking MDs, not osteopaths. Osteopaths, they're use Maximus, very interesting. But the medical board is still cranking on what they want to do. Have a lot. So it's for physicians, then probation teams, you better get in your own program. It can be, you know, there's a few of them. You don't have to use Maximus, you know, Pacific Assistance Group or what have you. And so the degree that there's actually going to be a diversion program somehow separate and apart from enforcement, the structure is already so built against that. I don't see that. Using somebody.
Thanks, Greg, for your thoughts on that. Anybody else have any comments or thoughts or feedback?
Helpful. This is Pam from Alaska.
Hey, Pam.
This is a helpful history. I've heard comments referring to California, but didn't understand the history of what had gone on. It's really sad.
It is. Thanks for giving that feedback.
Yeah.
Okay, if there's no other comments, I think we'll go ahead and end the webinar. Thank you guys for participating. This is the first attempt we've made at doing a webinar, so we may try again, and hopefully we'll get our act together as we learn how to do this. So thanks everybody for participating.
Thanks for putting it together.
Yeah, thanks.
Okay.
Greg. Good to see you.
Okay.
Greg.
Likewise.
Thanks, Jim.
Hey, thanks, Michael. Sorry I
Thanks,
couldn't
Mike.
hang out with you.
Yeah.
Thank you, Tom. Is that your dog barking, Greg?
No, it's
No.
mine, and I'm trying to get up. Okay.
Is that Ann?
It's me. Yeah, I have a new dog, a puppy, and he's just been
Okay.
horrible during quarantine. Sorry.
Hey, he just wants all your attention. That's all.
Okay. I think there's no attendees now. It's just us panelists. Can you guys hear me?
Yeah.